I'm particularly pleased to have the director, Professor Pratima Murthy, who will say a few words, and then I'll talk about the rest of the program.
Hi, good afternoon and good morning, everyone. I'm really very happy that a group of people has come together to look at the long-term care beyond what can be symptomatically possible to make sure that people with Huntington's disease have a reasonable quality of life despite their limitations. I think it was a couple of years ago that this initiative was started. Professor Jain and a team of people engaged in this activity started this and brought people together. I think the first and most important thing was really recognizing the diverse group of people that could come together to address this issue. Just yesterday, in fact, we were having a discussion with the neurology team on the whole definition of palliative care and how it could extend to various disorders, and how perhaps we need to look at continued care or extended care into the community, at home management at home if possible, and what might be the training, the background of the people who could do such provide such services as being very important. So I'm sure there's going to be a lot of discussion, a lot of practical themes. Can I request Mr. Imtiaz and Ms. Bhavna to mute your mics, please? Thank you very much. Thank you very much. So I'm sure there will be a lot of discussion as to what practically are the things that we need to do, in terms of individual care, what might be necessary in terms of developing programs, influencing policy. There are a lot of areas that this group can discuss and debate upon. And I understand that the Newcastle group has a lot of experience in this area. So I'm sure both the speakers from India as well as Newcastle will really throw light on many of these issues. And I wish this meeting all success. And I hope, what will emanate from it is a program of, extended or continued care for people with these disorders. Thank you very much.
Thank you, Pratima, and we look forward to your support and encouragement in the future. Meera, will you just carry on with the introducing the Indian speakers, the approximate outline? I'll join from my other machine.
Sure.
Okay?
Yeah.
Okay. Thank you.
So, hello everyone. Like Dr. Jain mentioned and Dr. Pratima mentioned, we are all here together to see what we can do to improve the cause of Huntington's disease care in India. And we have been fortunate to get this Newcastle group who have done a lot of work for looking after Huntington's disease patients in the northeast of England. And we are hoping that if they share their experiences, we would be better equipped to help our patients here in India. So the first speaker will be Dr. Suresh Komati, who is a neuropsychiatrist by training, and he has been seeing patients for a long time. Dr. Sanjeev Jain actually some years ago had been to the UK where he had actually seen their inpatient facility, and he was very impressed with what had been done and what is possibly, can be done. And many of them are very simple things which definitely we can provide for our patients here as well. And so the whole idea is to discuss and decide what things we can do and what we can implement here, because as you all know, many of you I know are from families who are dealing with HD right now, and you know what are all the challenges you face. So we are hoping that with some inputs with these people, we can also hope and aim to have similar things back in India as well. So like Dr. Jain mentioned, there seems to be some confusion because 11 o'clock British time was supposed to be 3:30, but apparently there is more than one British time, I think. So the conversion, there seems to have been some problem. So they'll probably log in pretty soon, and I'm sure they will enlighten us. So from the Indian side, Dr. Vikram Hulla and Dr. Nitish Kamble will be talking to us. So as many of you are aware, and some of you may have actually come to NIMHANS to seek help. So they are both neurologists in the movement disorder clinic here at NIMHANS. And on Saturdays, there is a clinic which particularly caters to the needs of movement disorder patients. So we have been seeing a lot of patients and over the years, and we've been trying to help patients to the extent possible. So they will also be narrating their experiences of the clinic. And then we also have Ms. Archana, who is going to narrate her experience as a member of an HD family, and probably also share what would be useful for people who are in that situation. What is the kind of help that they seek? So I'm hoping that we will have a very interesting time. Yeah, I see that Dr. Suresh has joined, as also Susan. So I'm very sorry. I must apologize for this confusion of time. Begna, has Dr. Jain joined you?
Yes, I'm here.
Yeah, okay. So then I think I hand over to you.
This is my usual problem with British time and GMT and BST and summertime and winter time. So I didn't realize it was the critical weekend when this changes over. So my apologies. And
you see that map there in the
so
same room?
So we started talking to the colleagues.
I request everyone to please mute their phones. Please kindly oblige and please mute your phones, everybody. Yeah, Dr. Jain, please continue.
Yeah. So we met Dr. Suresh on a brief visit to India, so I think about almost 10 years ago. And then about 3-4 years ago, I had a chance to visit the center at Newcastle. So I was very impressed with the kind of care services that would be provided on a long-term basis. And before I speak on his behalf, I hand you over to Suresh. So Dr. Suresh, over to you.
Thank you, Sanjeev. I'm Suresh Komati. I'm a consultant in Huntington Service in Northeast of England. Well, like Sanjeev mentioned, he visited us about 10 years ago, actually. And then we kind of showed him around about what we do here. And, we had a chat about how we developed to kind of, the service where we are at today. So that's where, Sanjeev asked me to talk about Huntington Service. I'm always kind of, proactive and pleased to talk about Huntington Service anyways. But to be honest, we were kind of preparing for at 11 o'clock. So, so it is an hour ahead. And, like most of us, I'm kind of doing last minute additions to the presentations and so on, which are not going to happen now anyway. So please bear with me. So I'm trying to upload my presentation. If you can bear with me for a couple of takes. Okay, can you see that presentation? Yes. Excellent, excellent. So I'm gonna make it like a slideshow maybe. Right, so I'm gonna talk about, how we kind of developed the Huntington service in the northeast of England. Well, I joined the service about 10 years ago, and the service existed even before that, about another decade before that, really. So we are in kind of, serving patients with Huntington's and families for almost, 2 decades now. I kind of happened to work with, the founder of this service as well. And then, we kind of talked about how we kind of, develop these services for very rare conditions like Huntington's and so on. So I'm gonna put some of his kind of, experiences as well as my experiences in my presentation now. I'm happy to take any questions after the presentation. Okay, so this is what I'm gonna talk about very briefly. And this man doesn't need an introduction, does he? especially to the group, we are kind of, meeting today. So obviously, he published his first work and his only work as a paper in 1872. So that's where he kind of, described a syndrome and managed to get his name to that condition, and which we are talking about even today. However, over from 1872, I think he's been kind of talking about this condition from 1860s and, and so on, 10 years before he published this paper. But over this kind of 150 years and so on, so what actually has kind of, changed in terms of, looking after Huntington's patients? Well, some clinicians may say that, yes, we have found a gene and we managed to diagnose patients even before they develop the symptoms. And it's a tremendous kind of, way forward in terms of, the whole diagnostics and so on for Huntington's. And some clinicians may say that, after that, what we do, in terms of the patients, we say that, there is no cure for Huntington's. And then, whatever they suffer, they have to slowly progress and so on. And in terms of, giving an interventions as well, it varies so much from, place to place and, area to area and so on anyways. So in a way, we are still kind of in a dark, most of the times when it comes to looking after Huntington's patients. And from the clinician's perspective, we could perhaps see that, there is a lot of progress in terms of gene silencing these days in the last, maybe 5-10 years. And, there are other kind of, researchers are coming through and so on. But from the families and carers and, patients' perspective, what actually changed? Is anything we could offer in our patients? Anything, we could suggest for them to follow where they can kind of slow down the progression or anything? So there's nothing much changed. So that is where we kind of think about, what actually a clinical service look like for patients with Huntington's where there is no cure existed. And why do we require a specialist service in the first place? Because, why can't, the Huntington's patients be looked after by primary care physicians or neurologists in the local areas and so on? Then we kind of, started to look at the patients and how they present to us. I kind of put up, like 4 scenarios from the patient group who we look after here. So I'll just briefly go through this very quickly. There's a 22-year-old man who is always getting into fights, and he's got minimal chorea, and he's got reckless, callous attitudes and behaviors, and he drinks, and after he got this genetic diagnosis, although he hasn't got any major symptoms, what his explanation was, he wants to enjoy life. And then, he kind of hit the bottle and, started to drink and, getting into fights and getting into criminal justice systems and so on. There is another patient who is 64-year-old retired chemistry professor with, gradual cognitive decline and, especially mainly the executive functions, which means planning, judgment, decision-making, things like that. And he's started to kind of having poor self-care, and the family started to really worry about him. And there's another patient who is 17-year-old man who got, so-called juvenile onset Huntington's disease, which is essentially manifesting or showing symptoms very early age. And he was quite into, the condition by 17. And he's presented with very kind of, slowing of the movements and very rigid and, very impulsive skin picking and, very sexualized kind of behaviors where there is a lot of, showing sexualized behaviors rather than kind of, any premeditated behaviors, if you like. And then he developed seizures as well. There is another patient who is 52-year-old doctor. He's a general practitioner in northeast of England, which is like a primary care physician. And he started to show, coliform movements, and then he developed a significant depression because of, he maintained insight for a long time. But, the main issue for him is depression rather than coliform movements. So what I kind of, try to say here is when we see Huntington's or when we say Huntington's, it's not one thing we are describing. This is a condition which can present and manifest in different ways and, many different ways. And, people do agree with me here, no two patients, even from the same family, can present, similarly with Huntington's disease. So what we're trying to do here is we are describing or categorizing, various different presentations and into one single category. And that is actually challenging in terms of, delivering a care in a non-specialist situations or environments. So that's where, most of the patients, most of the clinicians, it's difficult for them to kind of, see the varied presentations. And that actually kind of make a case for having a specialist service for Huntington's. I'm sorry for the special effects. I asked my daughter to kind of, do this presentation, and, she started to kind of, put so many special effects actually. Okay, so Huntington's can be described as chronic progressive neurological disorder, or a psychiatric disorder, or a genetic disorder, or young onset dementia. So it's overall, it depends on the clinician who they see and how they describe the condition. So that's actually kind of, warranting a requirement for a specialist service. When we started to kind of look into developing a specialist service, then we kind of looked at the whole kind of, area who we can cater for. And if you can see the cursor here, we kind of operate from the Hull, York area, and, from there to Scarborough, Middlesbrough. This is where we are based in Newcastle. And that's the Carlisle. And that's the Edinburgh, which is Scotland. So this is the vast kind of, geographical area we serve in terms of, providing a service for. So you can see how big this is a service. And you can see how kind of, very dense population here, and very kind of, people are scattered, and, the areas are scattered. So where, it's a large kind of geographical area with a, good transport kind of distances and so on. So that's essentially the area we cover in terms of, providing this service. So I've been to Bangalore, a couple of times, and, I can kind of see that, same dilemma in terms of NIMHANS is kind of, situated in the central heart of the Bangalore and serving patients and, populations very kind of very scattered, kind of almost a Karnataka district and so on. And that's pretty much kind of what we came up, what we had the problem in terms of developing a service. So before we started to develop the service, then we wanted to look at the prevalence, how many patients we have here. That's where actually the service kind of, to look at, how big is the service required for the scattering the service patient population. We had so many kind of, prevalence studies, and, people describe 3 to 7 per 100,000 population. In Japan and China, there is very kind of less common, and, this more common in, prevalence in Europe. But all these literature studies, does it really matter in terms of, providing a service for a defined geographical location like, Newcastle and northeast of England? Probably not. And that's where, these kind of clinical trials and the research published is very important. But at the same time, having a local developed sort of, numbers and research is vitally important for developing a clinical service. Then we kind of looked at, where do we get this kind of, patient numbers? And then the one thing is suggesting is genetic services, really. So then we approached the genetics. And then we kind of looked at, how many patients and families, they got, on their books. And then eventually kind of, looked at various numbers, and we managed to come up with around 600 patients out of 3.25 million population, in northeast of England. That's where, we looked at the, how is a rare disease defined? And, according to UK's kind of rare disease UK policy document, and 5 or less per 10,000, and, who requires a special combined efforts to enable patients to be treated effectively. So that's the definition for a rare disease. So that is how Huntington's qualify for a rare disease. In developing any research, service, we look at the policy documents and what is out there in terms of any directions or any provisions, any frameworks, what government propose or suggest, which probably can implement in developing our service. That's where we looked at the policy documents like Rare Disease UK and implementation strategy for Rare Disease UK. And we kind of based our service based on these three fundamental key objectives, such as facilitating earlier diagnosis and intervention, improving care coordination, which means that various needs can be coordinated and supported for the patients and families, and promoting research. So these are the key three objectives. So we took it to heart. Then we looked at what are the different barriers in terms of developing a Huntington service which can deliver an excellent quality of care. And the key barriers are small numbers of patients and dispersed over wide geographical areas, and distance of the patients to travel to attend the clinics. At the same time, the disability of the patients, which can limit the access to services as well. So patients do require, a level of home-based care and accessibility to expert multidisciplinary teams, and difficulties in developing local expertise due to heterogeneity of the presentations. What I described earlier on, the varied presentations, it's very difficult to develop, local expertise. And that's where integrating the clinical care and research, again, when patients, even though they want to take part in the research, it's a good distance they have to travel to take part into the research. So how best we can minimize that? So these are the key barriers we kind of identified in developing our service here. That's where we started the service, and and this is Walker Gate Park, where we are based as a community team and inpatient services for Huntington's disease. And this is a center for life where we do genetics and genetic diagnosis and outpatient clinics. So what do we provide in terms of looking at the barriers, in terms of taking the policy guidance in place and so on? So what actually the service over the time, we haven't, I'm not saying that it is over the night we have developed this kind of service in a month or in a year or in a couple of years really. So it is a good kind of 10 years journey before we kind of managed to get here. So there's a genetic counseling and testing, early diagnosis, outpatient reviews, early interventions, inpatient assessments, and community assessments for patients and families, psychosocial interventions where patients and the staff can go out and see the patients at their own homes and developing some interventions within the home environment, education to patients, families, caregivers, care homes, and other professionals, and clinical research in Huntington's. So this is where we are at a decade ago, and we gradually kind of developing over this service framework. In terms of providing the care, we looked at we took a triangular approach, in a way that the NHS is like a statutory health service here, and which teamed up with the Huntington's Disease Association, where you're going to hear from the John Greger, who's representing HDA today, about what they do as well. And we do meet up with patients, carers, and and so on every so often, which we call it as public patient panels, which is PPI we call it as. So I mean, this is like a triangular approach we took in terms of statutory with the voluntary organizations, with the patient's voice and family's voice in terms of shaping these services. And our model of care, we looked at what is the care which is probably optimal or apt to deliver to our patients here in northeast of England. Then we kind of looked at traditional care model and a care continuum model, and we come up with our own kind of a hybrid Newcastle model. Well, hybrid is a buzzword these days in many areas anyway. So we kind of thought Newcastle hybrid model is probably an apt name here basically. So in terms of who will provide this care, in a traditional care model, the clinician is the expert, where patient, clinicians sit in one office, and the patients go to clinicians for advice and interventions and so on. And the clinician is the expert and who kind of tell patients what to do. care continuum model where the clinicians are experts still, but they make patients expert because what the conditions we are treating is not as a one-off condition. It is a long-term progressive neurodegenerative conditions what we are treating here. So that's where making patients as an expert how to deal with some of these symptoms and prepare patients in the future in terms of what to expect and how to deal with them before it becomes a problem. And that is where making patients and experts as well is one thing which is vitally required here. And what we did was, not only the patients, but the local clinicians are making local clinicians as experts in terms of the physios and the physiotherapists and occupational therapists. We have a central resource where we have a specialist physiotherapist or an occupational therapist sit in Newcastle, but they liaise over the phone and nowadays video consultations in terms of the local physios and advising and dealing with the problems they face in looking after the Huntington's patient in the local area. So that is where we took up this kind of making the experts is not only in terms of the patients and the families, but also the local clinicians. And in terms of delivering the care, where to deliver the care? So it is driven by clinician's location. For instance, most of the times we open up an office-based, patient care or inpatient-based patient care in central part of the, Bangalore and so on. And we expect the patients to travel to come and see us. And like I said, there are lots of limitations in terms of, providing this kind of, transport for the patients. And, that's where they probably don't come and see you. So that's where, we thought that we probably, patient-centered care is probably a better option. Having said that, it is resource incentive. And again, it is very difficult to deliver in the practical terms. So that's where we took up the both in terms of the, clinicians' location. So we do some clinics as a clinician based in a central location where whoever can travel can, come and see us. And we go out, 1 day a week to different locations, and then we kind of deliver the care there in their patient, areas. And then when is again one thing is which is the key thing, which always puzzled me really, in a way that in terms of looking after patients, we deliver that we see you after 4 months time, or we see you after 6 months time, and so on. Depends on how best we can kind of cater for the outpatient services and so on. But when the patient, there is a change in their circumstances, in their clinical presentations and so on, if they want to see clinicians at that point in time, we don't have an appointments, and it's very difficult for us to kind of provide an appointment. So that's where we thought we leave some slots where patients can contact us, and then we can book them in. And that is where we are delivering both some patients who we think we can anticipate they're going to be stable in their presentation, and we provide a specific times in terms of the reviews. But and sometimes when we do see that patients can possibly kind of change their presentations very quickly, then we can ask them to ring us so that we can slot them in that kind of so-called crisis kind of appointments. And what do we deliver is clinical care only in the traditional care model, but in the care continuum model, both clinical and research, and we do both clinical and research. So this is where we developed this kind of a Dandelion model, where the hub and spoke model, where we kind of sit in center, Lair Walkergate Park in Newcastle, and we kind of make links with the OTs and the psychiatric services, physios and speech and language therapy services, social services, and so on. So we do have the contact numbers and the person who kind of interested in Huntington's and so on from various local areas. And then we kind of negotiate with them in terms of when we kind of come across a problem or a clinical presentation. So the fundamental, this is what I like the most in terms of, delivering Huntington's care really. So this is maybe rare, but hope should not be. When we kind of diagnose in terms of, Huntington's, so we say that, there's no cure, but having said that, there's a lot can be done. So there can be, please contact us so that we can kind of, try and deliver, or try and minimize our symptoms as much as possible. At the same time, being realistic, we might not be able to kind of, completely make them better, or, how they were premorbidly before they develop the symptoms and so on. This is a very busy slide, but this is just in the ideal world, who are all needed for Huntington service or effective Huntington service to deliver. A neurologist, a psychiatrist, a psychologist, a neuropsychologist. And the difference between them two is a neuropsychologist essentially look out for the cognitive changes, and the psychologist are probably counselings and about grief and loss of role in the family and the loss of various things really. And the geneticist and the social worker, physiotherapist, occupational therapist, speech therapist, there are a list of roles and responsibilities for various professionals requiring for delivering a service. But I mean, we all have to agree that it is not practical in the cost effective in terms of delivering, with such a team to develop, deliver Huntington services. But just give you a brief scenarios. Am I doing okay with the time? Because I can talk for a whole day, so you need to tell me when I should
Yeah, probably another 5 minutes or so.
Okay,
Yeah.
thank you.
So yeah, if you would if you could focus on this is what probably we would like to hear on how care can be provided. So yeah, please do take maybe another 5 minutes should be okay.
Thank you for that. Yeah, when it comes to Huntington's, it always happens to me really. I always go over the board and over the time anyway. So, well, just give you a brief scenario here. We got a 36-year-old gentleman, lives with his wife and 2 children, working in a factory and do odd shifts and so on. So, and he presented basically saying that, I'm not performing at work and I got loads of problems. And my manager is always after me and, he's giving problems and so on. And then wife reported that he is completely changed man, and he becomes very irritable, very snappy, and shouts at us, and is not kind of a dad to his kids anymore, kind of thing, and so on. And most of the times he's spending a long time in the toilet, where he's kind of isolating himself, away from the people and family and so on. Really, examination we found a bit of a chorea, which is not he doesn't see it as a problem like most of the Huntington's patients. And a bit of a motor persistence where very difficult to kind of perform this fine motor activities and so on. So we started him on antidepressant medication and a touch of antipsychotic medication, which we don't use it for psychosis here, but we do use it for treating coliform movements, and which is obviously not licensed for using to treat coliform movements anyway, but we still use it. And we make a referral to physiotherapist and OT, occupational therapist and speech language therapist and dietitian, because of the weight loss is the key concern. And then after, a couple of months time, we kind of reviewed him in the clinic, and we have, he presented with a bit of improved sleep, and, there is because he's sleeping more and better, and his irritability gone down a bit, his chorea has improved and mobility has improved as well. And he become a little bit more confident to perform at work, and he's kind of managed to kind of deal with the problems at work. And then we made a referral to genetic counselor, because they are worried about how they can bring up Huntington's with their kids. So following that kind of improvement in his mental state, then we referred him for neuropsychology for cognitive assessments. And that's where they found a strategies to deal with in terms of his cognitive sort of deficits and so on, so that he can perform a little bit better at work. So this is actually in terms of how we managed to contain his earlier symptoms of Huntington's. And then he volunteered in terms of participating in research, because he was very skeptical initially, because there's nothing can be done with Huntington's and so on. So but we managed to kind of change his opinion about, yes, there's a lot can be done, and they still can kind of lead independent life with involving the Huntington service. Most of the times we use staging as Huntington's is a tricky word really, because most of the neurologists or most of the psychiatrists and most of the Huntington's clinicians, they're based on the motor symptoms and to look at the staging. But there is a change of trend now, because we are using the functional capacity scales as staging here. I'm not going to go into the more detail into this slide. I just want to focus on a couple of minutes on this slide, really. This is This is a patient journey where, patient, how they develop in terms of their cognitive symptoms and, their physical symptoms and the psychiatric and behavioral symptoms and so on. And the patient diagnosed with Huntington's and, the immediate kind of, that's where the suicide risk is classed as very high. And that's where we provide that hope that, he still can be leading to independent life and so on. And after that, based on that level of staging, in terms of functional capacities and so on, we kind of do, identify stage 1, 2, 3, 4, 5. There is 5 different stages here. Each time when there is a change of presentation from stage 1 to stage 2, for instance, and stage 2 to stage 3, what the problems they're facing and, the complaints they kind of come up with is completely different. So in terms of, for instance, stage 1 and stage 2, the points is usually at the issues at work, finances, driving, and these kind of things they come up with as a problems. But in stage 2 to stage 3, impaired activities of daily living, which means, looking after themselves in terms of, dressing and the feeding and things like that. So each stage, there is a different set of problems so we are dealing with, and we deal with in terms of, providing the care for this population. And again, as they progresses, when they have first child, for instance, everybody, in the family gets worried about, whether they're going to pass gene to the child and so on. And that's where, there is an increased risk of suicide and, depression at that time. And disabled from work is another kind of, milestone where, most of the people can see it as a failure. And that's where we need to intervene more of psychiatrically at that point in time. So in every stage, every transition of these kind of stages, the set of problems is completely different. And then again, when it comes to stage 3 to 4, we usually kind of, bring patients in as an inpatient assessment, where, in the traditional model, if there is a problem we can't deal with in community, we bring the patients in. But in this kind of care continuum model, where, we preactively preempting the problems and we bring the patients into the inpatients, and we can deliver, we can do a comprehensive assessment and put the requirements in place or the needs in place, basically. So this is where, we kind of change the whole aspect of the care in Huntington's. I think I kind of touched upon this slide before. So in terms of principles of care in Huntington's, is caring for people is both challenging and rewarding, and telling people that there is no cure is very frustrating from the clinician's perspective. But symptoms evolve over the time at various stages, and these symptoms are completely different from stage to stage. That's the key thing which we need to deal with. And the interventions include patients and care education, person management, environmental management, physical therapies, behavioral and pharmacological interventions. There's a lot to be done, to be honest, this is where we struggle with the patients as well. When we kind of give it the diagnosis, then they say that that's it, nothing can be done. And, my life is completely gone and I'm not going to be kind of independent anymore. And this is where we kind of educate the patients that a lot can be done and various interventions can be available to treat the symptoms and so on. That is all, really. Thank you for listening to us.
Thank you so much. I'm sorry if we rushed you through it, but
No.
But like you rightly mentioned, you could speak forever and we could listen to you forever. But yeah, we have certain limitations of time, but I'm sure we'll have you back again and there'll be some questions from the audience later, which we will take. So,
absolutely.
Yeah. So I now call upon Susan, please, to come and deliver the next talk. I understand that Susan is the team lead who actually goes into the community and looks at patient families. So Susan, please share your talk with us. Thank you.
Hello, everybody. Thank you for inviting us along to your presentation. My colleague Gillian Thompson is in attendance with me as well, and Gillian's about to share the presentation we will be delivering. Are you okay to do that, Gillian?
Yes, just getting it started.
Go to slide 1.
Thanks, Sam.
Okay, so as you can see from the first slide, we are the Community Huntington's team. We are a very relatively small team. There's myself, who is the neuropsychiatry team clinical lead. We have 2 nursing community practitioners, who are Kat Nicholson and Stacey Whitaker. And we have 3 therapy staff, Gillian Thompson, who's with me today, advanced occupational therapist, Katie Oates, who's our advanced physiotherapist, Rebecca Alsbrook, who is our advanced speech and language therapist, and we have an assistant practitioner for the team. So we are a very small team at this moment in time. Next slide, please. So who are we? We, the Huntington Service, we're part of the neuropsychiatric services, and we're currently based at Walkergate Park. We are one of 2 dedicated services delivering comprehensive care for people with Huntington's who live in the UK. We operate between 2 trusts. One is the Cumbria Northumberland Tyne and Wear NHS Foundation Trust and Newcastle upon Tyne Hospitals. And we work very close in partnership with the Huntington's Disease Association, which is a voluntary organisation, and with primary and secondary healthcare providers and with social care providers. So we have close links with all community services. And what we try to do as well is to develop our services further and link in with further services as they develop. We get our majority of referrals are received from the genetic clinic at the Centre for Life, from our community nursing and therapy teams, the neuropsychiatry team, and from Ward 2 at Walkergate Park from their inpatient team. We have very, very close links with Ward 2 at Walkergate Park, as we feel that helps the journey and care and treatment pathway of people who are coming into the hospital from community and then being discharged back out of hospital, back into the community. So we maintain very close links with Ward 2. We do receive external referrals from other professionals. However, we have limited referrals received. We're unsure at this time as to whether that is because people aren't aware of the service, as we are a relatively new service. The therapy service has been, we've been developing this for approximately 3 to 4 years. So we are trying to get the word out there that we are here and we are about. The criteria of our service is people must have a diagnosis of Huntington's disease, either through genetic testing or a clinical diagnosis, and it meets our service remit. So what is our service remit? There is a dedicated therapy team to work with patients and families affected with Huntington's. At this time, it includes a speech and language therapist who works 3 sessions per week. We have a physiotherapist who works 4 sessions per week and an occupational therapist who works 5.8 sessions per week. So that's quite a limited amount of service that people are available at this time. However, we are trying to develop the service, which I will go into further down the presentation. And we have 1 full-time assistant practitioner. And the assistant practitioner, she supports all of the above therapists and the nursing staff as well. Due to the number of hours that our therapy staff are available, we can only offer community visits within a specific geographical area, and that is 60 minutes travel by car from Walkergate Park, which is our central base. That's for the occupational therapist and physiotherapist and our assistant practitioner support assistant. And it is only 45 minutes travel for the speech and language therapist due to the hours they actually work within the team. We decided on that to limit the hours to those, the travel distance to that, because we felt outside of those areas, we'd be diluting the team and the service that we could offer too much. It has raised ethical issues with us in the team, as the nursing team and our service is set up as a regional service, but the therapy part of the service is more local. It can't be offered regionally at this moment in time. The community practitioners, who in addition to working with people affected by Huntington's, also work with people with a neuropsychiatric condition. The community practitioners we do offer the geographical area of Cumbria, Northumberland and Tyne and Wear. Community visits to outside of the above areas are offered if service users are requested to be seen by our service, or if there are no locally identified services which can meet the person's needs. So what do we do as well? We provide specialist training in collaboration with the Huntington's Disease Association to families, carers, and external agencies. We feel this is invaluable to helping people receive the best care and treatment. We feel that it helps keep people in their homes longer, and it helps, like with what Dr. Komarte said earlier, it gives people hope. It gives people hope that they can continue to work with right care and support. There are things that can help people keep mobile, keep balance, reduce falls, and help people live a valued life in the community for as long as possible. We provide scaffolding, advice and training to other professionals, and that's both internal to our organisation and also outside of areas. So if somebody is outside the geographical area for, say, the occupational therapist to provide hands-on treatment to, they will liaise with the other professionals and other services, either by telephone, Zoom calls, FaceTime calls, and scaffold those services. We work very closely. We find it's very important to work in collaboration alongside colleagues regarding care pathways for people with Huntington's, to enable people to have a full understanding of Huntington's and how Huntington's can affect people cognitively, physically, emotionally, and within their families as well. We provide interdisciplinary team working with colleagues at the Centre for Life, the Huntington's Disease Association, and again with primary and secondary care services. This is a very busy slide. Unfortunately, we didn't have Dr. Komarte's daughter to help us do our slides and presentations, so we have no fancy work on ours, sorry. So what are the service objects and aims? Our main objective and our main aim is to enhance the quality of life of those patients, families and carers affected by Huntington's disease, to help them stay as active as possible at home, work and within local communities for as long as possible. We want to assist our patients and their families to make informed choices by providing them with up-to-date information based on evidence-based practice. We work alongside local services to increase knowledge and skills within this complex client group. We want to reduce avoidable hospital admissions by supporting patients to remain in their own homes. And we want to facilitate seamless admission and discharge to the community from Walkergate Park Ward 2. And we want to develop an equitable service, as our neuropsychiatry team is a regional service, and as said earlier, the therapy staff aren't able to cover regional service. Our service outcomes. By investing in a specialist Huntington's team, we ensure 6 out of 10 of the 11 quality requirements as outlined in the National Service Framework for the long-term conditions are addressed. We offer a very person-centred service. Everything we do is about the person, what they want, and how we can help them meet their goals. We offer early and specialist rehabilitation. We offer community rehabilitation and support, vocational rehabilitation, equipment and accommodation, and most importantly, we offer support for families and carers. So what next for our service? We've considered how to improve the service which we offer to people who have Huntington's. We looked, should we develop the current service we have for the therapy staff? We've recognised there are limitations on staffing and abilities to cover the geographical area of Cumbria, Northumberland, Tyne and Wear. And we recognise in doing this, there was a lack of ability to develop skills of other practitioners and therapists. Should we join a larger regional team, which is currently based at Walkergate Park, a therapy team, keeping the current therapy staff as clinical specialists? This would enable an equitable service to be developed for people with Huntington's. Therapy staff within the current team would be able to develop and enhance the therapeutic skills of the other therapy staff in that larger team. We've had meetings with senior managers and commissioners of services, and it's been agreed to move the service forward by joining a larger regional team who are based at Walkergate Park to enable an equitable service. and plans are now in development as how this service will look. And it is our hope that people within the region will have an equitable service, and we should be able to develop our service to help that happen. Thank you, Gillian, and that is the end of our presentation. Thank you.
Thank you. Thank you very much, Susan. That was very nice. I think, Dr. Jain, we actually have about 5 or 6 minutes. Maybe we can have some questions for the first two speakers before we continue.
Please, do we have questions in the chat box? We seem to have some in the chat box.
No questions as such. So maybe you could ask the speaker something.
No, this is, we've been discussing with colleagues here, and I see some of them online with our social work team and obviously the neurology team as to how we are going to, provide, as you correctly point out, the person-oriented continued care models, because seeing people come in is very difficult. So. Because they often drop out simply because of the inconvenience of coming to a big hospital. So that was very, very helpful to see how the care program transitions from ward to community care, to assisted living, and to home visits, and therefore keeps the person at the center of all the efforts. So we hope that we can develop services like this in the future, but managerially, I mean, when people need complex medical needs or complex, sometimes social welfare needs, or even legal and run-ins with the legal services, because sometimes, as you mentioned in the earlier case notes, some people can get very irritable and violent. So how does the status of being diagnosed to have Huntington disease? Is the system in general aware of the complex needs, or do we have to really struggle with all the different care providers and service providers to get help?
Yeah, I'm not unmute. Okay, thanks, Sanjeev. That's the real kind of a problem in terms of delivering a complex clinical care to patients, presenting with the varied sort of presentations and so on. I mean, there are two aspects to that really. In terms of developing and continuing to deliver the specialist level of care for the wide geographical area, most of the times you kind of explain to clinicians and the other professionals from various different backgrounds and so on, not necessarily what is Huntington's related symptoms, and most of the times what is not related to Huntington symptoms. Because, most of the clinicians put it down to, yes, you got Huntington, it's a neurodegenerative kind of, disorder and so on. So that's where, everything is kind of, linked to Huntington's and we can't do anything about it. So that's where, differentiating in terms of, what symptoms are actually, related to Huntington's and what are not in terms of is often a difficult task for us really, to be honest. And that goes with, criminal justice systems as well, in a sense that if somebody is having, say, so-called, the personality or antisocial personality disorders and so on, where they have very low threshold to deliver aggression because of their kind of background or because of their kind of, environments they brought up in, and whatever kind of attributes or whatever is kind of factors we attribute that to. I mean, on the other hand, where a person is quite mellowed and quite kind of not too kind of any irritable before, but started to get irritable and started to deliver that aggression over the time after developing the Huntington. So that's where the distinction is not clear cut in the first place, and sometimes it is a continuum rather than a discrete categorical models anyway, and that is often difficult in terms of what is Huntington's related aggression and violence and what is not really, And, either way, criminal justice system probably, some people think that, it is everything down to, the person. And some people think that everything down to the, disease or condition. And that is where, we kind of came up with some sort of a differentiating sort of principles in a sense that, essentially the cognitive changes are kind of a driving force in terms of, their low threshold to deliver aggression and violence and so on in most of the Huntington's related sort of aggression and, violence and so on, really. So that's where we do a bit of a cognitive assessments and look at the impulse control sort of thing and, look at the frontal lobe functions. And that is actually a base in terms of saying that, yes, Huntington's is playing a role in their behaviors. And no, it is not Huntington's, it is the person himself kind of thing, really. So that's the level of input we provide to CJS, criminal justice systems, which they kind of appreciate it quite a lot, and they can possibly kind of take the next steps forward based on the the person and what they have done and so on, really.
Yeah. Is Nikhil there?
Yeah.
Nikhil, would you like to? You've been working with these families the most. Any particular things you would like to?
I don't see him. He was there.
I
can see a couple of hands raised. Is
Biju, Dr. Kaushik, Dr. Biju?
Hi, I was just trying to understand when you started these services, because there are so many people involved. Did you start in a staged manner? Is it that you started with, let's say, these 3 or 4 kinds of things or kinds of services first, and then you moved on to the others? Because that will be something that you would want to understand. Just want to ask.
Yeah, I mean, it is a journey, really, to be honest. It didn't happen, in a short span of time, or in a year or a couple of years, really. So it took us about a decade or more than a decade, to be honest, in terms of developing the services and so on. But having said that, when we started, it's more or less like a clinician kind of a delivered service rather than kind of in a multidisciplinary team approach to the condition. Because it was, we're talking about 20 years ago, and it wasn't appreciated that these kind of varied presentations at the time requiring so many professionals to kind of bring together and then deliver the service and so on, really. So that's where eventually we kind of, as we see that presentation, then we kind of make a case for that, the professionals to step in and then provide the care and so on. And that's a challenge. And sometimes it is, hitting our heads against the brick wall, really, because it's very difficult to explain to, the fund holders or the buck holders to convince that, it's a valuable service, because if we put the money across now, we can prevent in so many other aspects of it and so on. So that cost effectiveness to show that to them is a big task for us. And, but we managed to kind of get there to a certain extent, in a sense that, yes, it is kind of a financially driven and motivated as well, in terms of, it brings some finances to the services, the way the service is organized here in this part of the world. And moreover, we took up a relatively kind of a non-traditional approach, I have to say, because we kind of started to do a bit of a pharmacological-led, clinical research, where, we kind of started to do, because we have a base and we have the Huntington's patients, so that, we can provide this kind of the so-called, helpful research to the patients groups anyway. That's the main motivation for us. But that opens up some financial channels as well, because, obviously we have this kind of, research personnel and team developed as parallel to the clinical team. And then we kind of using them judicially in terms of, transferring the cares and, looking and so on. So sometimes the service kind of attracted some money in terms of, participating in this clinical research. And that's the main kind of, driver for us to develop the research and so on. So which is a win-win, to be honest. It helps the patients to get participate in the, world-class research. At the same time, service getting benefited as well. So when I started, it is one consultant in the service, and eventually kind of we managed to get 3 more consultants to kind of share other kind of responsibilities so that I can focus on Huntington's and research. So that is how we developed really. I think it is a marathon, to be honest. It's not 100 meters, it is a long haul.
Yeah.
Dr. Kaushik.
Namaste to everyone. Yeah, see, we also started 2019, some HDSA society. I'm one of the founder member in India. Started something to provide solutions to patients. Okay, bringing the community of the people, doctors and neuro people and all together. But we are seeing that we are not able to do much like that. We have been feeling last 3 years. We are not progressing very much. That's the reason. No, we've been seeing what is the motivational behind you are able to achieve your goals. No, whatever you have achieved so far. Okay, what is the? Okay, that is one thing. Other one is still no in India. Say there is a constraint. People doesn't share openly. Okay, because the government also doesn't take care of this sort of rare disease. That's not at all. Government doesn't know at all. Unintended exists in India. Okay, that is status rather than now. Okay, only some Niemann people or somebody, some few doctors only knows in India. There is this one disease is there like this. Okay, so that we are trying to make awareness of the people as well as awareness of the doctors. Okay, we are trying to do. We have been aiming a very big thing. So I think your things might be something we may be able to learn something. Okay, still we are long ways there. So we have been thinking that we are not achieved enough in 3 years time, like that we have been feeling. Okay, we also get a frustration sometimes. We fight among ourselves. We have been quarreling among ourselves because the situation we are not able to move forward because in addition to that, this corona has come in last 2 years. He has eaten up our time. Okay, we are not able to meet physically also. So only we can able to have a talk on a Zoom and all. Really challenging. Financially, also we are not able to move forward. So I think we need to see that how you people have done something may motivate us. So what is your the main this thing, motivation background or what how do you could able to keep it up that decade you are telling? Okay, I'm seeing that I am get tired like that. I'm feeling now itself. Even I'm caretaker myself. Okay, right. I'm not able to achieve what I'm feeling that.
Sure. Well, to be honest, I share your frustrations, most of the times, and in terms of we get frustrated, and we kind of talked about among ourselves, and we kind of shout at each other, and we kind of put each other's throats and so on. That's normal, really, to be honest. That is the key kind of basis and success for a good and well progressed kind of service anyway. But when it comes to motivation, I think that's an interesting question in itself. To be honest, the way I see it is the motivation for us is like you have described. We haven't done enough. We haven't moved forward. After kind of 3 years time or so, and we kind of stand still. So those are the very feelings actually is the keys for the motivation. Even though we are making a little bit of progress, we still feel that we haven't done enough. There is a lot to be done. There's a lot to be delivered and so on. So that's the motivation. I can see motivation in your words anyway, because the frustration is the key for the motivation, in my opinion, really. So when I get frustrated about it's not enough done, I think that's the stepping stone for the motivation to do more. But in terms of what you are probably kind of, struggling, which I kind of, struggled a lot of time, is finding the solutions for the problems and how to take things forward. And that's where, we kind of feel like stuck and we're stagnant and we're not kind of, progressing forward and so on, basically. But I think solutions, come as you work in the, as you kind of think about it and how best you can, get other wider resources into the play. So that's one thing helped me in terms of, developing a service in terms of, getting the wider resources in play. For instance, I can share an example. We are struggling to provide care for especially the palliative care, where people are bedridden and they are really struggling, and it's very difficult for us to go and see them and so on. There are about 80, 85 patients on our books in terms of the advanced Huntington's disease. So at that time, we kind of thought about, it's taking a lot of time and, we are not providing enough for this patient group and so on. So then we looked at, what else, we could do and what are the resources we have. Then we came up with the palliative care teams are placed and, funded here locally. Then we approached the palliative care, clinicians, and then we asked them about, we got this patient group and, you need to look after them. What they say is a palliative care by definition, I mean, it's maybe harsh to say, but the patients won't survive for more than 3 months. So we can't hold them, patients who live longer in our caseloads. Then I kind of, suggested that if that's the case, and they got the needs, palliative care needs anyway, and all this patient group are really kind of having the needs of palliative care team, really. And you are saying that, because if they live longer, you can't provide the care, that's not kind of very fair. And then they say that, yes, but Huntington's, we don't know anything about it. And, that doesn't come under our kind of remit anyway. Then we kind of said that, yes, I am available over the, email at the end of the email, anytime. If you can provide that kind of care, and if you have any questions, and, shoot at me, and I can reply that to email within a week time. And then that started to kind of, work together, and then it started to take it up, and the local palliative care teams are actively providing, care for all these patients now. So we got, the teams came into the, they're very motivated and very proactive, and, in a sense that, they make a difference in terms of carers and the families and so on. So that's the key motive for them to get involved more and more, really. So that's how we kind of looked at, solutions for the problems, and sometimes we can't find solutions as well, and but that's not kind of, but again, that frustration of not finding a solution is a motivation, really. I think that's probably I have to say.
Thank you for those words. I think a lot of people here on this call have been through that frustration and the helplessness. I'm hoping that the next talk would help HDSI also to get some ideas on what we can do. So I invite now Mr. John Greger to talk about Huntington Disease Association, who we are and what we do. So over to you, John.
Great, thank you very much. I'll just share my screen. Okay, well, just to say thank you very much for inviting me today to talk. My name is John Greger, and I work for the Huntington's Disease Association. I've got 2 roles for the charity. I work 3 days of my working week is as a specialist advisor for the Northeast, and that's how I work with Dr. Komati and with the community Huntington's team. And the other part of my role is for the national charity, I'm the education lead. So just to give you a rough idea of what the Huntington's Disease Association is, it's a medium-sized charity, and it covers England and Wales. There's separate organisations for the other parts of the UK. And at the present, we support about 4,000 people, and that's people who have Huntington's, and it's other family members as well. So it's carers, people who are at risk of developing Huntington's. So it's a wide group of people that we work with. So this is our strategic goals as a charity. I won't talk through all of them, but just to give an idea of the sort of the mission that underpins the Huntington's Disease Association, particularly these first 2 goals around improving care and support for families where there's Huntington's, and around providing better knowledge and understanding of Huntington's. That they're 2 probably are the main things that drive our work. So the main part of our work as a charity is through the specialist Huntington's disease advisors, and the charity employs 19 advisors around the country. So we all have an area. So my area is roughly the same as the area covered by the community Huntington's team that Sue was just been talking about. So it's quite a big area, and I'm the only member of staff in that area. So we all work on our own. And like I said, we support people who are symptomatic, people who are at risk, people who have tested negative as well. And because sometimes the people who test negative and get a clear result still struggle. And a lot of our work is supporting carers. So there's 19 of us across the country, and the way we provide support is by telephone, email, Zoom, so virtual support. We do home visits when necessary. We run things like carers groups. We run family events and education, and we also support local branches and support groups. So just to give you a bit of an idea of the sort of things that we're asked about. So we're really there as a point of contact for families. So families ring us up and ask us, well, we don't know what until we take the call. And I've been working quite a long time in this job, and on a weekly, if not daily basis, I'm asked something that I've never been asked before. So the sort of things we're asked about are things like about managing symptoms and behavior, money problems, insurance, work, driving, finding the right sort of care and support, finding the right equipment, questions about research, questions about leisure activities, questions about carer support, questions about future planning, people that want to talk about getting tested or what they should do, people who are maybe struggling to get someone with Huntington's to accept support and care. There's always things that we haven't been asked before. And we don't always know all the answers straight off to anything that we're asked, but what we have is lots of contacts where if someone does ask a question that we don't know the answer to, that we can usually find them an answer. The other part of this role is be there to provide emotional support. So often we're taking calls from people who just want to talk, but don't particularly expect an answer, that they just want to be able to talk to someone who understands the condition and has some understanding of what they might be going through. So sometimes that's people with Huntington's, and sometimes it's other family members. So it's people, carers and partners who maybe are really struggling to provide support for someone at home and are frustrated and don't have anyone else to talk to. Because obviously, as we know, Huntington's is a family illness, and sometimes talking to other family members can be difficult because everyone's got their own position on the journey of Huntington's. So sometimes it can be useful for people to have someone outside the family to talk to. The other part of our role is to provide support to professionals working with people with Huntington's. And again, that's the way we do that. It's telephone and email and in virtual meetings. We do quite a lot of joint working with other teams. So obviously I work with the community Huntington's team that Sue was talking about. We work with social workers and all sorts of therapists around the region. We do get involved in some safeguarding cases as well. All the advisors around the country provide training. So we all provide training to different people who are working with people with Huntington's. So that might be care homes, or it might be domiciliary care agencies who are going in to support people at home, or it might be different like social work teams or mental health teams who maybe haven't had much experience of Huntington's. So we do training with anyone really who asks us to do that. Some of my colleagues around the country are actually work into the clinics, because what we find is we all work slightly differently because services around England and Wales are set up slightly differently. So sometimes there's in the northeast, Dr. Kamarti does lots of clinics, satellite clinics, but in other areas there's more like one big clinic. So where there's one big clinic, sometimes some of my colleagues work directly into those. This is just I'm not going to talk through this. This is just an idea of all the different people who sort of we would work with. So obviously a wide range of people. There's a couple at the bottom, the HDYES and the JHD advisor, who I'll just mention who they are a little bit further into a talk. So this is, the charity is lucky enough to be able to fund someone who can dedicate 1 day a week solely to working with families where there's juvenile Huntington's disease. So this is Helen, and she does a variety of things specifically to support those families, because, as I'm sure you're aware, juvenile Huntington's disease is quite rare compared to the adult onset form. And so a lot of those families feel quite isolated because they don't necessarily know anybody else who has the condition. So part of Helen's role is to provide that support, and she does things to bring those families together. That one of the main things that we organise is a yearly weekend away. It's a kind of outward bound activity weekend, where some of the young people get to do activities while their families can meet and so to meet and talk, and to try and reduce some of that isolation that they feel. Other things that Helen does is look at like Zoom meetings and WhatsApp groups, things just to create a bit of a community around that. We also are lucky enough to have James, and James is our youth engagement worker. So James covers the whole of the country, so the UK, the England and Wales, and James's remit is to work with young people, children and young people in families where there's Huntington's. So we're not talking about people who have juvenile Huntington's, we're talking about children who are just growing up in a family where a parent has Huntington's, because as we know, that can cause, there can be quite a lot of issues for people who are in that position. So a lot, obviously to do with watching a parent become poorly, or to do with how the parent's behaving towards them, a lot of those children can struggle, and it's James's role to support them. He works with schools to try and increase understanding with the schools as well, and James does get involved in quite a lot of safeguarding issues as well. So James is really there for someone independent for those children and young people to contact and to talk to. And this is my other role is as education lead. So my remit is to improve the quality of what we offer in terms of education to families and professionals. So it's looking at what training we're delivering across the country, trying to improve that, trying to make sure that we're reaching out to people to let them know that we do training, and to try and make sure that across the country we're delivering that service equally. One of the other things that I am involved in organising is a professional course. So at the minute we're running this online, so anyone in the UK or outside the UK can access it. And it's what that is, it's an online course, and it runs over 3 days, and we get a variety of speakers on all different aspects of Huntington's, and it's a really good in-depth introduction to Huntington's, and we do things like have workshops, and so part of the idea is that other professionals who are working with people with Huntington's can meet each other, because Huntington's is quite rare, it can be quite isolating for some professionals, because they don't necessarily have other colleagues who necessarily work with people with the condition. So it's a chance to meet other people who are working with people with Huntington's. Another big part of my role as education lead is to organise webinars, and we're organising 1 or 2 of these a month. And these are available for anyone to book onto, and they're free. And we organise them on a wide range of topics. So some of them might be more of interest to professionals, and some of them might be more of interest to families. And often that are of interest to both. So just to give it an idea of things that we've done recently, we had a webinar this week about driving, and we've had webinars recently about PGD and about we've got one coming up in a week about a research project, and we've got a whole range of topics that we deal with. We've had one recently from a dietitian. So we try and cover lots and lots of topics that people who are in families where the Huntingtons are interested in, and also for professionals. And what we do is our webinars sort of have two lives, because you can book on them and attend them live, and that you can ask questions, or we record all of them and then put them on our YouTube channel, so they're all available to watch afterwards as well. So just to say briefly, we have about 39 branches and support groups across the country, and these are often run by volunteers. A lot of this has been gone online during the pandemic, and so we're sort of emerging into a slightly new world with this, because during the pandemic some of the branches have closed down, but we're hoping to start building these back up again. And some of the advisors like myself run some of these support groups. So I've started running an online support group to cover the Northeast. HD Voice is just something we run as a charity. It's a focus group. So when there's research proposals, HD Voice can look at it to get input from the point of view of families where there's Huntingtons. So, and often when we produce new materials as a charity, HD Voice would look at that to see if we're doing it right, and if the family, if it's that we're not just wrapped up in giving information to professionals, that it's suitable for families as well. We offer grants, so we can offer small grants of up to £350, and these are for often for goods for people to carpets and fridges and washing machines, those sort of things. And so this can be really useful, because obviously money problems are very common with a lot of the families we deal with. So this is a really useful thing that we can tap into. We also, as advisors, if we can't get money from the national charity, we do support people to look for other sources of funding as well. We also run it's been a bit stop-start, but due to the pandemic, but we've got a care home accreditation scheme, because one of the problems that a lot of the families that we work with have is that when they're looking for a care home, they don't know if this care home understands Huntington's, and it's very difficult for us to recommend places, because obviously staff change, managers change, the quality of care goes up and down. So with our accreditation scheme, homes who apply to be part of this have to submit a folder of work to show that of what they're doing to specifically cater for the needs of people with Huntington's, and that some of my colleagues then go out and do an observation. So it's just so we can recommend these homes with some confidence. So we've got about 6 homes at the moment, which are either been through this process or are going through it, and we're hoping that this is something that we can build on, just so we can recommend homes with some degree of confidence. Other things that we deal with are we do a lot of things with young adults, so people who don't have Huntington's maybe, but are at risk, or maybe found out that they do carry the gene but aren't symptomatic. We do events to bring those people together. We run things, we're trying to cater more and more for people who are tested negative, because we've identified that this is an area where people actually can really struggle. People who maybe have got a good test result, so they know they're clear of the Huntington's gene, but then they've got siblings who do carry the gene and they struggle with guilt, all these people who maybe have thought for a long time that they do carry the gene, and then have maybe made life decisions based on that. So maybe not had children, not followed what they wanted to do in terms of work, thinking they were going to get poorly. And then actually when they find out they don't carry the gene, there can be quite a lot of anger. And so testing negative isn't necessarily as straightforward as it might sound. So we try and support those people as well. We run a national carers group. So once a month, we run an online carers group nationally. And obviously I've mentioned about the webinars. Yeah. The main part of one of my main part of our roles is provide awareness, and each year we're running an awareness month, which is in May. So this is last year's awareness month. We worked with the other Huntington's organisations in the UK, so Scotland and Ireland and Northern Ireland, and commissioned a website where families could share their stories. And this year we're again working with the other UK charities, and we're producing a series of what we're going to call family voice webinars. So we're giving family members a chance to tell their story. That's just ways we can be contacted. The main thing I would point in the direction of is our website, which has got loads of information on if you're interested. And that's sort of all I've got to say. The only thing I would say that you know, if there was anything that in terms of information that we could support with, I'll be very happy if people wanted to get in touch with me, and that I'll be happy if you know, if there's anything I've said that you'd want to find out more about, you know, please get in touch. And I think that's about it.
Thank you very much, John. That was a very enlightening and lucid talk, and it was very encouraging, because like Kaushik mentioned, we members of HDSI have been very confused on what we should do. I have one question for you. You mentioned that you have 19 advisors across the country. So what is the qualification? Like, what is your background? Because we've always wondered that, you know, we want somebody at the end of the phone for a patient to reach out, but who should that be? Because you really, like you mentioned, you have a whole load of questions that might come your way. So what is your qualification and background?
Yeah, exactly. That's a very good question. And we're all from different backgrounds. So just within the team, we've got some people, my background's social work, and we have other people whose background's nursing, and we've got someone whose background was like physio and an OT, an occupational therapist. And so we've got other people have managed care homes. So we've got a really wide range of backgrounds, and that's a big advantage for us, because what we do, you know, when I was saying we often have questions where you think, I've never been asked this before and I don't know what the answer is. What we do is we'll put questions out to our colleagues. So often if it's not something we've come across, someone else has. So we use each other as a resource. So that's one of the ways that sometimes we can get answers for people, because actually it is drawn on the experience of the team, and we talk between the 19 of us, we talk a lot. We talk all the time. So every day there's emails flying around saying, someone's asked me this, I don't know what it is, or I don't know how to answer it. Has anyone come across this before? So that's one of the ways we sort of draw on each other as a resource, if you like.
Mm-hmm. Right. Yeah, this is quite amazing. Yeah, I hope sometime down the line we can provide at least a fraction of what you've been able to do. It's really quite amazing. I think we have to move on now, but I'm sure that you will definitely, you know, get emails from us, and you know, I'm sure many of the colleagues here would like to participate and in your webinars, and probably also listen to the recordings. It will be a very good starting point, I think, for many of the junior clinicians who, you know, would like to participate in HD care going forward. So that was a very, very very useful presentation. So I think we have to move on now to the next talk, but I'm hoping we'll have a few minutes at the end for discussion and questions again. So thank you very much, John. I now invite Vikram and Dr. Vikram Holla and Dr. Nitish Kamble, who are both physicians at NIMHANS in the movement disorder clinic. So they will talk to us and tell us about their experiences of seeing HD patients. So Nitish, would you like to take over, please?
Yes, madam. Yes, thank you. Thank you, madam. Very good evening to all. I am Dr. Nitish Kamble, Associate Professor at the Department of Neurology in NIMHANS, Bangalore. So I am a part of the movement disorder team. The team comprises of Dr. Pramod Kumar Pal, who is a professor and head, the chief of movement disorder team at NIMHANS. Then we have Dr. Ravi Yadav, who is an associate, he's a professor of neurology, and Dr. Vikram Holla, the assistant professor of neurology at NIMHANS. So we work closely with Dr. Sanjeev Jain sir and Dr. Meera Purushottam madam in managing patients of Huntington disease. So we as a team are involved in providing care and support to patients with Huntington disease. Our institute, being a tertiary care center and a referral center, we receive a lot of patients of Huntington disease from all over the across all over the geographic locations in India. And our main objective is to provide clinical services in terms of diagnosis, management, providing support and care to patients with HD, Huntington disease, and even their caregivers, and with an objective to improve the quality of life of both the patients and the caregivers. In addition, we train health professionals and resident doctors who are involved in taking care of patients with Huntington disease. We also undertake various research activities, and basically with our interest through this research activities is to understand the pathophysiology of the disease in terms of its motor and non-motor symptoms, and translate this information into clinical practice. We work closely with the departments of psychiatry, psychiatric social work, neurorehabilitation, and we have a multidisciplinary team, so which are involved in the treating these patients and improving the quality of life of patients with Huntington disease. And periodically, the patients and the caregivers are also educated about the disease progression, and we educate them about the measures that they need to take to reduce the symptoms, both the motor and the non-motor symptoms. And our movement disorder clinic at NIMHANS functions every Wednesday and even on the first and third Saturday of every month. So educational activities are being held periodically for patients as well as for the healthcare professionals, and to increase the awareness among these people. And also we have a website wherein patients can reach out to us for further information. And with the formation of Huntington Disease Society of India, the public outreach has become much more easy, and they are able to access us without much difficulty. I hope that in future many patients and families will benefit by becoming a part of the society. So my colleague Dr. Vikram Holla will now provide the details of the various research activities we have undertaken in this institute. And I thank all of you for the patient listening. And I thank Dr. Sanjeev Jain sir and Dr. Meera Purushottam madam for giving me this opportunity to talk on this occasion. Thank you, sir. Thank you, madam.
Thank you. Thank you very much. So Vikram will be telling us about his experiences on the research front. Yeah, Vikram.
Good, I think.
Yeah, are you able to see my screen?
Yeah.
Yes.
Is it in this this one? I mean, slideshow or?
No, it's not in slideshow.
I'll just. No.
Yes.
Yes.
Fine.
So at the outset, I thank Dr. Sanjay Jain sir and Dr. Meera Purushottam ma'am for giving me this opportunity. So as my colleague Dr. Nitish sir told, so we in Niman's Parkinson's disease and movement disorder subspecialty, our team consists of Dr. Paul, who is our mentor and guide and head of the department of, the subspecialty, along with Dr. Avyada, Dr. Nitish Kamble and myself. And we have various PhD scholars and postdoctoral fellows and junior scientific officers who help us in managing the patients with HSD. Sir has briefed you all about the clinical activities and the healthcare workers and building activities and all he has worked. So patients come to our clinic basically most of the times either they are already diagnosed, they come for a second opinion, or sometimes they also come without a diagnosis and they get diagnosed as Huntington's disease at our clinic. There is a major chunk who are already diagnosed, already know what it is about, but still they come to us looking for any way to be part of the research so that they can enhance the understanding, our understanding through them, and so that we can help them and the future patients better. In that aspect, we have been doing some of the studies. These are a couple of two previous studies. The recently published one where which was where psychiatric morbidity and poor follow-up underlie the suboptimal. So according to this, again, it is this study showed that it's important to give a holistic care because in order to improve the quality of life of those patients who are amenable for interventions. There is increased risk of dropouts, increased percentage of death due to illness and also suicidal tendencies. And these patients, if given proper care and proper holistic care, maybe they can have a better quality of life and prolonged survivals. And also there was one more study. So one more study where we studied just the underlying pathophysiology, what is evaluation of cognition and its relationship with the cortical excitability. So this again, showed that TMS is a very valuable method for evaluating cortical excitability in HD patients. Apart from that, there are various other studies where we studied different determinants of onset of Huntington disease with behavioral symptoms, how is its association with psychotic abnormalities in patients, and also a review on eye movement abnormalities in Huntington disease. So based by these studies, we tend to understand better the disease so that the patients can benefit by better management and better care. And when it comes to Huntington disease, more often we tend to, as a neurologist, may tend to focus on the motor symptoms, that is the involuntary movements. However, the majority of the quality of life may be, the burden maybe because of the non-motor symptoms also, like sleep, psychiatric comorbidities, depression, anxiety, hallucination, psychosis. All these features also may be the major part of the illness which may be affecting the quality of life. So this also needs to be considered, and on this front, we are doing a study where we are studying the non-motor symptoms, quality of life, and caregiver burden, which is also very important in patients with Huntington's disease. Apart from this, apart from the involuntary movements, we also want to study like what is the pattern of gait and balance evaluation, like what is the postural instability, how it affects the day-to-day activity of the patients of Huntington disease. And this aspect also we are doing studies, studying these aspects. So whichever patients and the family are interested in being part of these studies, they can reach out to us. As Dr. Nitish told, we are available every Wednesday and Thursdays, also first and third Saturdays to be part of these studies. Thank you.
Thank you very much, Dr. Jain and Meera ma'am and everybody. And thank you, Dr. Suresh and team for taking us through this process. We are, as Dr. Jain mentioned, the term palliative care itself, we are trying to find new meanings for that while we are working with chronic neurological diseases. And Huntington's require a lot of advanced support, as Archana mentioned and as Pooja mentioned. And I'm sure everybody, all of us, Kaushik sir, all of us are quite familiar in this group. So we are trying to develop certain systems which could be contextualized and tailor-made to our clientele is what we are hoping, Suresh sir. Basically, starting from a clinic point of view, as Dr. Nitish and Vikram were mentioning, and the clinic which, the genetic clinic services that has been running for many years now. So all these things we want to bring together so that the process, the trajectory that you mentioned from early diagnosis till palliative care and how families and caregivers can be supported through this process. That is what we would like to kind of reach out. We have made a little bit of a initial or a beginning in this, and it has been very useful listening to multiple components that are coming together in your work, in NHS-led as well as clinic-led, community-led, and even the HD Association. So I'm sure all of us in this group, we can find ways to work together and take from clinic and research and everything come together under same umbrella, so that we hold on to the hope that we have. And families are, while we are holding on to the hope and research and the new things that are coming up, we also ensure that quality of life is maintained. That's what we are trying to reach out. And we hope we can reach out to you as we go forward, Dr. Suresh and Susan and all of Susan left the group, I believe. So we will need a lot of support. We would reach out, please. As we go forward, I'm sure that it's a periodic process. As you mentioned, it has taken 10 years for you to reach, the kind of structure that you have developed. And we hope that little by little, we will be able to reach a little better understanding and better process. Thank you so much. It was wonderful listening to all of you. Thank you, sir.
Thank you.
Thank you, everyone. Happy weekend.
Absolutely, Priya. Absolutely, Priya. Anytime, actually, drop us an email and I'll get back to you. So as Sue Lawrence as well and John Gregor as well. So they're very, very supportive, really.
Thank you very much.
Perhaps, since we know, in a sense, this conference has got I'm wearing two hats, and so is Meera, and so are many of the others, in which the fact that we are also clinicians and we are also trying to to get this Huntington Disease Society off the ground. So I think with people like John, it would be very useful for the non-medical colleagues in HDSI to develop links with them directly and see how civic society can be encouraged to take, to take part in all this. As Suresh, as you correctly pointed out, with Huntington disease, the patient is often the best expert, not the neurologist or the psychiatrist, because the patient, in whatever way, knows exactly what they need and what the needs are for the future. And learning to live with that kind of specialist knowledge, I think, with the wider society is very, very important. So that will be a real effort, most of the so-called LMIC countries, especially in India, which is such a large population, rare diseases get neglected completely. Now, you said in your entire area, you have 600 patients. So to tell somebody in the government that you need this care for 600 or 1,000 patients, they will not listen to it. But it's the human aspect of it, that a patient and an individual needs care, and that's the very important message that we need to keep on addressing. Anybody else has any queries? Do I see any hands? I'll just run over the list.
Just want to make a quick comment, Sanjeev, if I may.
Yeah.
Archana is a very inspiring talk, actually. We need more people to come out and share their experiences, especially how they dealt with the diagnosis of Huntington's and so on. Because often, the day we give the diagnosis to them, everything falls apart. And they quickly identify how their parents been through, and they quickly identify with their parents what they've gone through in terms of the problems and the symptoms and all the rest of it. So often I use the phrase like you are just like a person how you were yesterday, and today happened to be with me and I'm giving the diagnosis, and tomorrow you'll be the same person as well. So nothing going to happen to you in tomorrow or day after, basically. So it is a slow progressing condition. And that's where, it's completely different. You don't have to be like, going through the same as your parents gone through and so on. But, like Archana did, that's where, people have to come forward and share their experiences and so on, which is probably the key thing what the patients and families to, bank upon to deal with this kind of devastating condition and so on, really. So I think that's a great talk, Archana, what she has given.
Thank you very much. Thank you very much, Suresh.
Sir,
can you speak, please?
Nikhil, sorry, I can't see all the hands. Please go ahead, whoever is talking.
Yes, sir. Thanks a lot for giving me a talk for this one. I just wanted to ask one thing for this one. As such, I have gone there. There is a genetic session as such. Dr. Alok, the doctor who was from the name as they said, they're having a session. I have sent an email because I am from Delhi.
I see.
But I didn't get any response from them that if I can come over there and have an appointment with them or something like that for this. As such, in Delhi, we are having a general neurologic and for this one. I tried many, but I couldn't come up with that. Please.
I look into it, sir, because I know the All India Institute has a specialist service, but I'll try to connect you specifically with that service. Dr. Nikhil, would you like to add anything?
Thanks a lot. Thank you.
Thank you.
Hello?
Yes, Nikhil, please.
Yeah, sir. It was a great session. All I have to say is thank Dr. Suresh Komati and the team to come forward and do this. And I think we have learned some lessons and we would take this forward. We would continue to engage with you and exchange information, strategies, and probably get feedback from you. And it was a great session. That's all I can say. Thank you very much.
That's absolutely fine, Nikhil. And like I said, drop us an email, and we are, more than happy to kind of share our experiences and so on. Not a problem at all.
Thank you. Thank you very much.
Yeah, I'm hoping that once we get some critical mass of young people who express interest in, working with this field, we can reach out to you to probably hold one or two, some kind of a webinar or something on the, because we are hoping that as part of HDSI every month, we will have some kind of an activity, and it would be great if, you or some members of your team can address particular aspects, because this was the general overview. Like you correctly mentioned, there is balance, there is speech, there are so many other aspects, and each of them actually deserve a full hour so that there is time for patients to ask specific questions, and also many of the clinicians and there are also some nurses and therapists who we can, bring on board. If some such training becomes possible, it would, I think, be very useful. It would give us the confidence that we have some hands to hold on to. That would be probably useful. So I'm hoping that I do see a lot of doctors from NIMHANS who have logged in, and I'm hoping that some of them would continue to, help us in this, because it's really very difficult for Dr. Jain or Nikhil by himself to handle all the, patients, because we are beginning to realize that it is not as rare as we first thought. We have been giving out so many reports, and every family has its own set of problems, like you rightly said. So we really need as many hands as possible. So that's why I was asking John, what is his qualification? Because we are really at a loss, as to who is the person who should pick up the phone and, answer when an HD family calls, because they are very varied with the kinds of problems that they might have. So we hope, like Dr. Priya also mentioned, we hope that we'll all work together and create some kind of group of people who can reach out, at least in Bangalore to start with, and then slowly also train people in other parts of India. That's very important.
I mean, just to add to that, when we started initially to take these kind of advices to and support to the care homes, then we don't actually know what to tell them basically. And apart from Huntington's can manifest in so many different ways, and this is how you could possibly step in and address and so on. So and then we started asking questions about what do you want to know, kind of thing. And then they kind of started questions, and then we collected all those questions and we kind of shaped our kind of advice, and as we went along. And then we came up with a bit of a leaflet and so on to address a common questions which flare up and bother most of the carers and so on, really. So I think that's perhaps probably the way forward in terms of gaining that kind of clinical experience and so on, really.
Mm-hmm.
So I think that's probably what I can suggest for that at this point.
Sure.
But I probably finish by saying, thank you to Susan Lawrence and, John Greger. We're having a day just like in Bangalore for some, just it's very rare to have this sunny day here. So it's like an excellent day out here, actually. But despite that, Sue was here, John was here, and because most of the time people are kind of, spending time outside in the sun, which is very, very rare here at this part of the time. But this is the motivation, we had, we blessed with, so many people had, really. So that's where, I have a special thanks for both of them. And, thank you all, to listen to me and, Sanjeev and Meeraji and, so inviting us as well. Thank you.
On behalf of both NIMHANS and the HDSI, thank you, Suresh, and your colleagues, Susan and John, for making the effort on having to skip their breakfast probably. By a miscalculation of summertime and winter time. So apologies for that. Thank you for stepping into the breach so quickly, despite this disruption. Thank you all for making the time and sharing your experiences. And we look forward to your continued help and support, and let's working cooperatively with you to answer these issues. Thank you. Good evening to all those in India, and have a good day ahead. Thank you.
And just one moment, there was a message that was put in the chat box in the beginning. Right. So I request all of you to write to that email and give your name, your email ID, and who you are, so that we can get back to you, when we have related, whether it's an educative program or a patient support, so that we can reach out to you. Thank you very much, Suresh, and thank you, John.
Thank you. Thanks a lot.
Thank you all.